السلام عليكم ورحمة الله وبركاته. معكم دكتور ياسر طاقة. I'm going to talk to you in this lecture about management of head injuries. You know that this is the third lecture in head injuries and it is the last lecture inshallah in head injuries. We spent 3 lectures for head injuries because of its importance in your medical practice. It is very, very important, a very common problem you are going to be facing in your daily life. First of all, the key aspects in the management of head injuries are the following. Number one, accurate clinical assessment of neurological and other injuries. Number two, determination of the pathological process involved. And lastly, changes in neurological signs indicate progression or change in the pathological process. Now, this third point is quite important. Regarding accurate clinical assessment, you know that we are going to examine the patient, to take good history from the patient and good examination. And I'll give you some details about this, inshallah, in this lecture. Then determination of the pathological process. I mean, what is the pathology? For example, scalp laceration, for example, bone skull fracture, or intracranial injury to the brain. And the last point, which I told you it's important, that changes in neurological signs will indicate a progression or change in the pathological process. We mean that sometimes the patient, for example, present with a trivial loss of consciousness, and then at a presentation, he was fully conscious. The loss of consciousness was at home, and in the way to the hospital, he regained his consciousness. Now, if I see that this patient start to get decreased level of consciousness, this means that some pathological process is going on, which needs sometimes for intervention, like for example, hematoma. The management plan, the program for managing head injuries, I will put this lecture into these 5 parts. Number one, dealing with the life-saving priorities. Number two, initial evaluation and examination of the patient. Number three, necessary investigations, for example, skull X-ray, CT scan, or others. Continuing care and observations, possible needs for surgery to evacuate an intracranial hematoma. And we'll give you some details about each point of these quite important points in the management of head injuries. Number one, the first part is the life-saving, how to deal with the life-saving priorities, and we mean the ABC. A for the airway, B for breathing, and C for circulation. Protection of the airway, and how to protect the airway of the patient by cleaning and putting airway tube or intratracheal tube sometimes may be needed. And I must tell you that you must be able to distinguish between airway and breathing. Airway refers to the protection, I mean the patent airway from the nose or mouth to the lung should be opened and patent all of it all the way. While breathing is the mechanism of respiration, I mean is the patient breathe or not, and is his breathing regular or irregular. These are quite important, and we must prevent hypoventilation. Then circulation, I mean, for example, arrest of hemorrhage, correction of shock, and maintaining adequate blood pressure. And now you must know these 2 important points or not. That patients are more likely to die from airway obstruction rather than any other treatable intracranial lesion. I mean, for example, extradural hematoma is top emergency, as you know. But will I take the patient directly from the casualty or emergency department to the surgical theater without doing airway? No. So first of all, I will deal with airway, breathing, circulation, then to go take the patient. And number B, this is quite important point as well, that the presence of shock in a patient with head injury is most likely due to internal hemorrhage in the thorax or abdomen rather than due to the head injury. And now this is quite common problem we are facing every day. Every day we are facing this problem, that a patient, let me say, I call him as multiply injured patient, exposed, for example, patient exposed to road traffic accident, car accident. He will get not only head injury, he may get also chest injury, abdominal injury, even fracture femur maybe, for example. Now, this patient will present as unconscious, the doctors in the casualty, they will think that this level unconsciousness is due to head injury. No, please, please, please. I always say it in three times. Please, please, please check the pulse of the patient at least. In fact, it's necessary to check the pulse and blood pressure. The pulse and blood pressure of the patient, but at least, please, please, please put your fingers over the radial, brachial, or the carotid pulse. Feel the pulse, and from this, you will feel if there is pulse or not. This is quite important because, or how is the volume and the how is the rate of pulse, so that from this you can get good information. Because, for example, hypovolemic shock will not result from head injury. For example, our top emergency, as I told you, always extradural hematoma. How many cc of blood will be inside the skull to cause extradural hematoma between, I mean, the extradural space? If I say 1 liter, no, it's impossible because the size of the brain. This 1 liter means there will be herniation. The patient will be died. Or 1 pint, I mean 500 cc, also very huge amount, very big amount. The total amount of blood which we are facing in open when we are opening the case of extradural hematoma, we will see only, for example, 50 cc, maximum 100 cc, not more than this, because bigger than this volume, the patient got either herniation of brain and result in either permanent deficit or the patient may be dying or died. Okay. Lastly, care must be taken to secure the neck and spine by putting collar around the neck and by careful body movement and until to be sure no spinal injury. We are supposing always put in your mind the following sentence, that any case of head injury is associated with cervical injury until proved otherwise. So that once you are receiving a patient having an injury, you must, with the ABC, put the rigid plastic collar around the neck, and this plastic collar must be of the type which will prevent the up and down movement, I mean extension or flexion of the neck, and also prevent right and left movement of the neck, and also to move the patient as one piece, because sometimes they may be associated, for example, thoracolumbar injury or lumbar injury. At that case, we may change patient if he's having unstable fracture, for example, but has no any deficit in the lower limbs. But by our movement, if you did not take care in the during movement of the patient as one piece, we will let the patient have also injury to the spinal cord or the nerve roots and may get paralysis or paralysis of the lower limbs. This is the oropharyngeal airway which we are using for patent airway of the patient. This is the endotracheal tube, sometimes is needed for the patient, and in fact, inshallah, this is sixth class. I will give you clinical session about these important subjects. And this is the collar. You can see this is called Philadelphia collar. This is the rigid collar, plastic collar, but this differ from that present in the market. That one have no support for the chin, only just like cylinder to prevent movement of the neck up and down. This one will prevent up and down, also will prevent right and left turning of the head, I mean any movement of the neck, right or left. As I told you, we suppose that any patient is having injury is having also a cervical injury otherwise, so that we put this neck with the ABC, with the aerobic circulation, until we are sure 100% that there is no cervical injury, then we can remove this. And in fact, how you will be sure 100%? By at least to do for the patient lateral X-ray of the cervical spine to see if there's no fracture or dislocation. Then we are going to the second part in the management of head injuries, which are the initial evaluations and examination of the patient. I will put this into three parts. Number A, important points in the history. Initial examination. B, and this is the quite important point, what are the indications for admission to hospital in patient having head injuries. Regarding the history, what are the important points you are going to ask any patient or relatives or attendants or witnesses who are having present at the site of trauma or injury during the time of accident? You will ask for the cause or circumstance and mechanism of injury. Ask about the period of loss of consciousness. Is there loss of consciousness or not? And how long was the time for loss of consciousness? The period of post-traumatic amnesia. Can he remember everything or not? Presence of headache and vomiting because they may indicate to me that there is increased cranial pressure. Level of consciousness at the scenes and on transfer. I mean, at the site of scenes and the site of accident, how was level of consciousness? And during transfer, you may ask, for example, the driver of the ambulance or the medical staff who was with the driver who are taking the patient from the site of accident to the hospital. Also ask about any evidence of seizures. Is the patient got seizure or not? Probable hypoxia or hypotension. For example, if a patient was incarcerated inside, for example, a closed building. Pre-existing medical conditions like, for example, hypertension, diabetes, or if the patient is having, for example, medications, especially anticoagulants. You know, many patients are taking this as a protection, for example, after CBA, like aspirin. Illicit, I mean, illegal drugs and alcohol, for example, addicted patient, because they will, this patient, for example, if a patient addict on alcohol and he was drinking, of course, this drinking alcohol will result in decreased level of consciousness, which may be just due to alcohol intake. And you will put this patient under observation for a few hours, and after the effect of alcohol will disappear, the patient may regain fully conscious, and you can reassure him. The next part is the initial examination. What are the important points? We concentrate upon them in the initial examination. The vital signs, we mean the pulse, blood pressure, and respiration. Examine the scalp for any, what we mean by scalp macellation or scalp hematoma, as I told you in the first head injury lecture. Examine the scalp by, of course, by palpation. You'll feel if there's any fracture. You can see, for example, linear or depressed scalp fracture. Level of consciousness by using the Glasgow Coma score, which I gave you details of it in the first head injury lecture. Examine the pupils for size and reaction to light. Put in mind the following points: that immediately dilate the pupil after the trauma or after the injury, they indicate direct trauma of the orbit or the oculomotor nerve. While pupils dilated later, this is lateralizing sign due to supratentorial hematoma like extradural hematoma. Also, examine the patient for lateralizing signs like hemiplegia in the acute phase is more likely to due to primary cerebral injury rather than due to compressing intracranial hematoma. I mean, just as I mentioned in the last slide, that, for example, pupils immediately dilated due to direct trauma of the orbit or oculomotor nerve, while pupils dilated later due to lateralizing signs, for example, increasing size of hematoma. Now, for this also, hemiplegia in the acute phase is more likely due to primary cerebral injury rather than due to compressing intracranial hematoma. But later on, if the hemiplegia is developing later on, this means that there was no hematoma at first, and now this hematoma is increasing in size. Also, examine for signs of basic skull fractures, skull base fractures, and you know this very well, like one eye or battle sign, etc. Physiological examination for limbs, tone, power, sensation, and reflexes. Examine the limbs for any fracture or vascular injury, because this may be the cause of disturbed level of consciousness due to, for example, shock, for example, fracture femur. Examine the chest for fracture ribs, pneumothorax, or hemothorax, because these will result also in, for example, in shock state, and in also this shock state will result in decreased level of consciousness and also in dyspnea and sometimes apnea. Examine the abdomen for internal hemorrhage or peritonitis. Examine the back for the possibility of fractures or dislocations of the spine, because as I told you that any case of injury is associated with cervical or injury, and maybe also multiple injured patients may be having also other injuries in the body, and we must exclude them. For example, in the examination, you can see inequality of pupils. This is the enlarged pupil rather than this one. Also, you can see as well. Now, this is the Glasgow Coma score. I told you the details of it. I will not repeat it again because I mentioned it in the first lectures. Now, this is the quite important slide, which is the indications for admission to hospital in case of head injuries. These are quite important points. You must put your attention to them because they are very important. Now, when I am going to admit patient to hospital and when I let him go home, if you will face patient having one of these, you must admit him to hospital. Number one, any depression, the level of consciousness, or any history of loss of consciousness for more than 5 minutes, you must admit the patient to the hospital. The skull fractures, whatever the skull fracture, whether linear or depressed skull fracture, also you must admit the patient to hospital for at least 24 to 48 hours. For neurological signs, hemiplegia, paresis, or inequality of pupil size, also you must admit the patient for the hospital. Persistent headache or vomiting, which are features of increased cranial pressure, you must admit the patient to hospital. Patients who are difficult to assess, for example, those who are also intoxicated, like for example, he was on alcohol. Concomitant disease or medications that pose increased risk for example, coagulopathies and anticoagulants, because they may be having more risk for bleeding than others. And lastly, absence of responsible relatives who can observe the patient for the first 24 hours. What do you mean by responsible relatives? Not only the presence of responsible relatives, but I will examine these relatives. I mean, I will not clinical examination, but I will assess them. Are they have good IQ? They can manage their patient at home, and if there's any deterioration, they are able to bring him to the hospital at the proper time. All these I must put in my mind. يعني باللغه احنا بلغتنا شو نقول؟ احنا نقول انه اذا كان الاهل المريض يعول عليهم وتشوفون هذول قادرين على انه يتصرفون بحكمه مع المريض، انه اذا اخذوه على البيت مثلا بامكانهم اذا صار تدهور يجيبون لنا اياه ممكن نطلعوه على البيت، اذا لا شفناه ما ثقه مثلا يعني خلينا نقول ثقافتهم قليله ما يقدرون يعني يتصرفون بشكل جيد، لا طبعا بالحال هذه الافضل انهم بقيه عندنا. ايضا يعني الظرف اللي احنا عايشين به والمكان اللي هم عايشين به، مثلا اذا كان بيتهم قريب عن المستشفى ممكن اقدر اخليهم يروحون اذا عندهم سياره ويقدرون يوصلون عندنا. اذا صار مثلا حظر تجول او مثلا السير مثلا مكانهم بعيد مثلا لا نكون باقيين في المستشفى. يعني كلها ظروف ندرسها قبل ما نقرر انه المريض ياخذوه على البيت الا نبقي في المستشفى. The third part of management of patients with head injuries are the necessary investigations. And as I told you, that we have the plain X-ray of the skull and of cervical spines, and then CT scan of the brain. Regarding the first one, I mean, a plain skull X-ray, it can demonstrate the site and type of skull fracture. I mean, for example, this is linear or depressed skull fracture, and the site, exact site, for example, right frontal, right parietal, and any other order. Also can show to me if there's any foreign body can also be seen, like shell injury or wound injury inside the head can also be seen by this skull X-ray. Now, it's important to mention to you that you must take two views of a skull. Let's say the AP and the lateral view. For example, this skull is say AP view showing to you multiple linear skull fractures. This one, this linear skull fracture on the left side, and these are the site of the suture lines. I mean, this is the sagittal and the lambdoid suture. Also, you can see the lateral view can show something is not to be shown with the AP. So that you must do two views in skull X-ray AP and lateral view. What are the indications for skull X-ray in head injured patient? Any patient presented to you with impaired consciousness or neurological signs, a patient having history of loss of consciousness or amnesia or fits. You know, to exclude any possibility of any injury inside the skull or inside. High-speed injuries or suspected penetrating injuries, skull lacerations due to bone and large hematoma or suspected fracture on palpation, persisting vomiting or headache, loss of cerebrospinal fluid or blood from the ear or nose, which are the indicators of skull-based fractures, and difficulty in assessing the patient, like children or drugs or alcohol intoxication. In these cases, you must do skull X-ray for this patient with head injuries. Then you must do for any patient having head injury, cervical spine X-ray, at least to do lateral view to exclude the fracture or dislocation of a spine, because as I told you before that, any patient who is having head injury is having also cervical spine injury until proved otherwise, and you must put the collar, rigid collar, in the neck of the patient until you exclude presence of a fracture or dislocation of the cervical spine, and this is best done by doing at least lateral view in the cervical spine. Then the final investigation, most important, is CT scan of the brain. It is done, maybe done immediately, and sometimes need to be repeated later on. Now, when I do immediate CT scan of the brain, in fact, these indications are very, very important. You must know them very well. The indications for intermediate CT scan in head injuries are: number one, Glasgow score of less than 13 at any time, at any point. Okay, this which means that there is decreased level of consciousness, not fully conscious. A Glasgow score of 13 or 14 at 2 hours after the injury. Phonological deficit is also an indication for immediate CT scan to exclude, for example, brain injury, or for example, extradural hematoma or hematoma. Suspected open, depressed, or basal skull fractures all are in need for immediate CT. Seizures, because in order to know what is the cause of this seizure, maybe, for example, some contusions inside the brain. Vomiting, more than one episode, also indication for immediate CT of the brain. Age more than 65 years, because this patient may develop, for example, small subdural hematoma, for example, which is not to be seen clearly by clinically, not presented clinically, because as I told you in the last lecture, that there was a big space for the blood and accumulation of blood, and to present clinically need at least 21 days for presentation. Coagulopathy, patient, for example, on warfarin, you must do CT scan to exclude, because they may have hidden hematoma. Dangerous mechanism of injury, here the CT scan should be done within 8 hours. Antegrade amnesia, more than 30 minutes, and CT scan to be done within 8 hours. Now, these are the indications for immediate CT scan to be done for the patient, but sometimes we are in need to repeat the CT scan after a while. If there is delayed deterioration in the mental state, for example, he was very well, but after for example, 3 hours or the second day, he got deterioration in the mental consciousness. Persistent rise in the intracranial pressure, because this one may indicate, for example, expanding hematoma, which was small yesterday. Now, for example, at the morning was small, but at the evening enlarging, or this night it was small, now then enlarging. Persistent rise in the intracranial pressure, to know the cause of it, and failure to improve over 24 hours, and this patient is in need for the repetition of the CT scan of the brain. Now, after we did the first aid and assessment of the patient, and then investigations, by these investigations, you know that we will know very well about the diagnosis, the final diagnosis of the patient. I mean, what was the pathology in this patient. Regarding continuous care and observation, the aim of conservative treatment are to give the patient the maximum care until spontaneous recovery will occur. And number two, to detect at the earliest possible moment the development of complications that may need surgical interference. For example, patient got a fractured skull, transverse temporal skull fracture with injury to the medial meningeal artery. There will be start to collect hematoma. Now, at first it was not apparent. I mean, clinically he was well, and the CT scan showed no collected hematoma. I admit the patient to hospital, and close observation, development of complications in the patient, I mean deterioration level of consciousness, they will give me a red flag to interfere, for example, to do CT scan repeated again and to exclude expanding hematoma. Continuous care, I mean not only at the early as possible, for example by ABC, but also to continue to observe the patient, even if the patient, for example, I decide to treat him conservatively. For example, the patient is having only brain edema, no fracture, for example, no hematoma. I will treat him conservatively, but this patient will be in need for attention to the airway still, because he may develop apnea at any time, or If there's an obstruction, secretions may be secretion, and this will lead to suffocation and then apnea. For escalator, to facilitate the nursing care and to estimate the urine output. You know that without escalator, he will urinate on himself and the bed will be wet. But with escalator, the things will be cleaner, and also we can estimate the amount of urine output. Frequent change of posture to avoid bed sores. Every 2 hours, we must change the position of the patient. Physiotherapy of the joints and massage to the muscles, also to avoid contractures. You know, we mentioned these things because some of our patients are in need for they will long time stay in hospital, for example, or in bed because they still unconscious, for example, 20 or 30 days. Intravenous isotonic maintenance fluid should be given crystalloids until nasogastric feeding starts, and we must start nasogastric feeding as early as possible if there's no contraindication to this. Nasogastric tube feeding, and in fact, what are we going to feed the patient? The same as the food of the home. All will be changed to fluid by a blender and given to the patient by nasogastric tube feeding. Measures to decrease the intracranial pressure. Here, you must pay good attention to the following points, please. Before mannitol, you know that mannitol is very good in decreasing intracranial pressure, but before mannitol is given, it is essential to exclude intracranial hematoma, for example, hematoma, and to check that the renal function is satisfactory, because if there's renal function problem, mannitol is contraindicated, and if there's expanding hematoma, why? As mannitol reduces normal brain volume, it will increase the size of extradural hematoma, and so it will increase the mass effect. So that why it is harmful in case of hematoma. In case of hematoma, for example, let's say that this patient is getting starting to expand extradural hematoma. It was of small size, but during this associated with the brain edema. This brain edema compress on the with the hematoma will compress on the source of bleeding. Bleeding will stop, and extradural hematoma will still small. But if I give the patient mannitol, what I will do, this will lead to decrease in the size of the brain due to decreased edema, and then hematoma will have good area to expand, and the bleeding will not be able to stop. So that is harmful. Steroids in severe head injuries are associated with increased mortality and should not be used, so that they are contraindicated to use the steroids in head injuries. Also, in continuous care and observations, we must do repeat observations of the level of consciousness using the Glasgow Coma score. As I told you that we don't want single reading of Glasgow Coma score. The most important is the repeated reading of Glasgow Coma score. For example, let me say to you, if you have two patients and went to the hospital, one of them is having the Glasgow Coma score of 15, the other one is having 13. Now, if I ask you which one of these is better, you would definitely say that this one who is having Glasgow Coma score of 15 is better. This indicates mild head injury, while that one with 13 indicate moderate head injury. So that this one, first one with 15, is better than the second one. After 1 hour of follow-up, I saw that the first one who was having 15 Glasgow Coma score got 14, while that one with 13 is still 13. Now I'll ask you again, which one now is better? You will say no, the second one is better because it's stable, while the first one is disturbing and there's a great of consciousness. For example, after 2 hours, you will see that one is 13 and then 12 and so on down, while that one is still 13. So that repeat observation of level of consciousness using Glasgow Coma score is excellent in following the patient. Also follow the frequent reading of the pulse, blood pressure, and temperature of the patient. Also observe respiration, size of the pupils and reaction to light, and examine the reflexes. And also this point of continuous care observation, what are the causes of deterioration in patients of head injury? Number one is brain edema, because brain edema sometimes may be starting as a small, but then it will increase much more. And inside this, as I told you always, the closed box, I mean the skull, there will be compression on the brain and may even lead to herniation. Airway obstruction and or hypoventilation leading to brain swelling. Airway obstruction and hypoventilation, they will lead to hypoxia and hypercapnia. and the brain will be in need for more oxygen. To get more oxygen, there will be vasodilatation in the vessels of the brain to take more blood, which is containing low amount of oxygen, and they will lead to more and more brain swelling. Intracranial hematoma, if it is small and then enlarging, fever due to respiratory infection or meningitis are quite an important cause of deterioration. Overtransfusion by hypotonic fluid or oppositely dehydration. And lastly, epilepsy. All these are the cause of deterioration in patients having head injuries. And the last part of management of patients with head injuries are the surgery to evacuate, for example, acute intracranial hematoma. Now, most of the patients who are having head injuries will be treated conservatively, in fact. And to start with, we are saying always that head injury is a general surgical problem, not a neurosurgical problem. It is treated by a general surgeon. To start with, so I repeat again that head injuries is a general surgical problem and can be treated by general surgeon. Sometimes they are in need for intervention by neurosurgeons, like evacuation of hematoma. Once the clinical picture of the patient deteriorates, the possibility of intracranial hematoma is raised, and it is so important to exclude or verify this because surgical interference at this stage can save the patient. Otherwise, progressive deterioration and fatal herniation of the cerebellar tonsil and medulla through the foramen magnum will occur, and death of the patient will happen. Regarding long-term sequelae of head injury, in fact, sometimes patients with head injury are left with some problems. Number one, neurological deficits. This needs neurorehabilitation by medical, nursing, physiotherapy, and speech therapy and occupational therapy team. For example, change of job from active job to less job. Post-traumatic epilepsy, it affects less than 5% of patients admitted with head injuries and maybe early or maybe late. I don't want to enter with you long details about this post-traumatic epilepsy, but put in mind that less than 5% of patients with head injury will be having also post-traumatic epilepsy, whatever the type of head injury. Cerebrospinal fluid fistula, this mainly after, for example, CSF, rhinorrhea, otorrhea, and sometimes through compound skull fracture to the outside. A neuropsychological sequelae, we have what's called post-concussion syndrome. It is a complex of symptoms persisting months after head injury and consists of various combinations of headache, dizziness, impaired short-term memory and concentration, easy fatigability, emotional disinhibition, and depression. In fact, this syndrome, post-concussion syndrome, is sometimes difficult to treat. For example, I will convert my patient to the psychiatrist, and even in this with the psychiatrist field, treatment of this patient would be quite difficult. And lastly, neuroendocrine and metabolic disorders, for example, affecting the pituitary gland may got, for example, the patient may got diuresis, antidiuretic hormone problems. Lastly, we have what is called the outcome after head injury. Outcome after head injury is graded into, as you see in this what's called the Glasgow outcome score, into 5 grades. Either good recovery with 5 points, moderate disability with 4 points, severe disability 3, persistent vegetative state, which I mentioned to some units about it, and 2, or lastly, death of the patient. Now, what do you mean by each one of these? Good recovery. The patient will be independent, functioning, and possibility of returning to work even if this deficit is present. 4, with moderate disability, the patient remain independent though with a disabling deficit. A deficit, but can do his job. Severe disability with the score of 3, dependent on others for at least some of their care. And persistent vegetative state have no awareness of themselves or their environment. In fact, this will pass into regular cycle, sleep cycle. For example, at 8 a.m. in the morning, they will be awakened and open their eyes. but they are in bed. They are not able to move, unaware, no awareness of themselves. And for example, at 12 p.m., they will go into sleep. After, for example, 3-4 hours, they will be awaking, and then at night, at 12, for example, 12 a.m., they will go into sleep. And this is they are in need for frequent change in posture, and in fact, it is major disability. And the last one with score 1, I mean death of the patient. So this is what's called Glasgow outcome score. Lastly, to summarize all the lectures of head injuries, please put this slide into all this in this slide are quite important. Put them in your mind strongly. Don't forget them, please. So that in head injury, don't forget, number one, that changes in the Glasgow score are often of more importance than the absolute score, so that you must monitor regularly the patient to say whether this is improving or not. Be aware of associated injuries and manage severe head injuries as multiple injured patient until other injuries are excluded. So that put in your mind that he may also having a cervical injury or chest injury or abdominal injury or pelvic injury or even sometimes fracture femur. Stabilize the neck, please, with the ABC. Put the collar, rigid collar around the neck of the patient to avoid movement right or left or up and down. Be aware of intoxications with alcohol or drugs, and these, in fact, will let you treat the patient differently. Record keeping beyond approach. I mean, for these 2 points, you must always record everything you know see on the patient, and also if the patient, for example, want to go home on his responsibility, let him sign and keep these papers with you. And lastly, and this is most important, if in doubt, admit. I mean, admit the patient to the hospital. Once you have seen that this patient is suspicious of anything bad, admit him to hospital. Don't يعني بنحكيها باللغه العربيه، لا تحمل نفسك انت مسؤوليه، انت تشك فيه انه هذا 1%، مثلا شفت انه حتى اذا شفت الفاميلي مثلا ما متعاونين معك، زين، انت اصر على مساله الادمشن تو هوسبيتال، زين، ادمشن تو هوسبيتال. اذا رفضوا خلي يوقعون على مسؤوليتهم، محتفظ بالأوراق انت يمك اللي موقعين عليه، لانه this patient, for example, may get deterioration at home and they are unable to, for example, to bring him to the hospital again, may die on the way from home back to the hospital, and they will blame you, that you will say, I asked you to admit your patient to hospital, you refuse, and this is your sign. Okay, so this is quite important. If in doubt, please admit. Please admit. Thank you very much for listening to this lecture also, and I hope that these lectures to be important for you and beneficial to you in your daily medical life, inshallah, and first for the exam, inshallah. Thank you very much. And if you have any question, you don't hesitate to send the answer to me, and I hope to see you in other lecture, inshallah. والسلام عليكم ورحمة الله وبركاته.